and adjust it so that it is parallel with the foot and ensure that there is no rotation. So, angulate the central ray 10 degrees toward the heel to the base of the third metatarsal. So, this shows an AP projection of the tarsals anterior to the talus, metatarsal, and phalanges. Next, the lateral projection lateromedial. So, the IR used must be 24 by 30 cm lengthwise. So, position of the patient, supinate the patient, turn the patient into the unaffected side until the affected leg and foot are laterally placed. So, center the IR to the middle area of the foot and adjust it so that the long axis is parallel to the long axis of the foot. So, the central ray is perpendicular to the base of the third metatarsal. So, this shows a true lateromedial projection of the foot, ankle joint, and distal ends of the tibia and fibula. So, next we have the AP axial projection of the foot, weight-bearing composite method standing. So, the IR used must be 24 by 30 cm lengthwise. So, place the patient in standing position, standing upright position. Adjust the IR under the foot and center its midline to the long axis of the foot. So, direct the central ray at the base of the third metatarsal. So, this shows a full outline of the foot is projected free of the leg. So, we proceed to the AP oblique projection of the foot, lateral rotation. So, the IR used must be 24 by 30 cm lengthwise. So, place the patient in supine position. Flex the knee of the affected side enough for the plantar surface of the foot to rest firmly on the radiographic table. Rotate the leg laterally an angle of 30 degrees. So, the central ray is perpendicular to the base of the third metatarsal. So, this shows the interspaces between the first and second metatarsal and between the medial and the intermediate cuneiforms. For the medial rotation, place the IR under the patient's foot parallel with the long axis and center it to the midline of the base of the third metatarsal. And rotate the leg medially at the angle of 30 degrees. So, the central ray for this projection must be perpendicular to the base of the third metatarsal. So, this shows the interspaces between the cuboid and the calcaneus, the cuboid and the fourth and fifth metatarsal, the cuboid and the lateral cuneiforms, and the talus and the navicular bone. Next is the axial projection plantodorsal of the calcaneus. So, the IR used must be 8 by 10 inches. So, place the patient in seated position with the legs fully extended. So, place the IR under the patient's ankle, center to the midline of the ankle. Have the patient grasp the gauze to hold the ankle in the right angle dorsiflexion. position to obtain a true AP projection. So, flex the ankle and foot enough to place the long axis of the foot in a vertical position. So, the central ray for this projection must be perpendicular through the ankle joint at a point midway between the malleoli. So, this shows a true AP projection of the ankle joint, the distal end of the tibia and fibula, and the proximal portion of the talus. So next, the lateral projection of the ankle, mediolateral. So the IR used must be 8 by 10 inches. So supinate the patient and turn toward the affected side until the ankle is in lateral. So place the long axis of the IR parallel with the long axis of the patient leg and center it to the ankle joint. Ensure that the lateral surface of the foot is in contact with the IR. So the central ray for this projection is perpendicular to the ankle joint, entering the medial malleolus. So this shows a true lateral projection of the lower third of the tibia and fibula, the ankle joint, and the tarsals. So next, the lateral projection of the ankle lateromedial. The IR used must be 8 by 10 inches crosswise. So have the patient in supine position and turn away from the affected side until the extended leg is placed laterally. So place the IR into the ankle joint and center it. Adjust the IR so that its long axis is parallel with the long axis of the leg. So the central ray for this projection is perpendicular through the ankle joint, entering 1/2 inch superior to the lateral malleolus. So this shows a lateral projection of the lower third of the tibia and fibula, the ankle joint, and the tarsals. So the mortise joint AP oblique projection of the ankle, medial rotation. So the IR used for this projection must be 8 by 10 inches lengthwise. So place the patient in supine position. Assist the patient by internally rotating the entire leg and foot together 15 to 20 degrees until the intermalleolar plane is parallel with the IR. So the plantar surface of the foot should be placed at a right angle to the leg. So the central ray for this projection is perpendicular, entering the ankle joint midway between the malleoli. So the inter-ankle mortise joint should be demonstrated in profile. The three sides of the mortise joint should be visualized. Next, we have the lateromedial oblique projection of the foot, Isherwood method, medial rotation. So the IR used for this projection must be 8 by 10 inches. So place the patient in seated position, turn away from the side being examined. So with the medial border of the foot resting on the IR, place a 45-degree foam wedge under the elevated leg. So since we do not have a foam wedge, let's imagine that we put some foam wedge. So the central ray for this projection is perpendicular to a point 1 inch distal and 1 inch anterior to the lateral malleolus. So this shows the anterior subtalar articular surface and an oblique projection of the tarsals. The face mannequin method produced a similar image representation. projection, Isherwood method, medial rotation ankle. So ask the patient to rotate the leg and foot medially enough to rest the side of the foot and affected ankle. So the central ray for this projection is directed to a point 1 inch distal, 1 inch anterior to the lateral malleolus at an angle of 10 degrees cephalad. So this shows the middle articulation of the subtalar joint and an end-on projection of the sinus tarsi. So for the apiaxial oblique projection, Isherwood method, lateral rotation ankle, ask the patient to rotate the leg and foot laterally until the side of the foot and the ankle rests against the optional 30 degrees foam wedge. So, the central ray is directed to a point 1 inch distal to the medial malleolus at an angle of 10 degrees cephalad. So, this shows the posterior articulation of the subtalar joint in profile. So, we proceed to the AP projection of the knee. So, the IR used must be 24 by 30 cm lengthwise. So place the patient in supine position and adjust the body so that the pelvis is not rotated. So with the IR under the patient knee, flex the joint slightly, locate the apex of the patella, and as the patient extends the knee, center the IR about 1/2 inch below the patellar apex. This will be center of the IR to the joint space. So, the central ray for this projection is directed to a point 1/2 inch inferior to the patellar apex. So, this shows an AP projection of the knee structures. So, let's proceed to the lateral projection of the knee, medial lateral rotation. So the IR used must be 24 by 30 cm lengthwise. So ask the patient to turn into the affected side. Ensure that the pelvis is not rotated. So a flexion of 20 and 30 degrees is usually preferred. So the central ray for this projection must be directed to the knee joint 1 inch distal to the medial epicondyle at an angle of 5 to 7 degrees cephalad. So this shows a lateral image of the distal end of the femur, patella, knee joint, proximal ends of the tibia and fibula, and adjacent soft tissue. Next, we have the PA axial projection, home blood method. So the IR used for this projection must be 8 by 10 inches. So let the patient kneeling on the radiographic table as originally described by Holmland with the affected knee over the IR. So place the IR against the anterior surface of the patient knee and center the IR to the apex of the patella. Flex the knee 70 degrees from full extension, which is the 20-degree difference from the central ray. So the central ray for this is perpendicular to the lower leg, entering the midpoint of the IR for all these positions. So this shows the intercondylar fossa of the femur and the medial and lateral lengthwise. So, place the patient in prone position and adjust the body so that it is not rotated. So, flex the patient's knee to either a 40 or 50-degree angle and rest the foot on a suitable support. So, center the upper half of the IR to the knee joint and the central ray angulation project the joint to the center of the IR. So, the central ray for this projection is perpendicular to the long axis of the leg and center to the knee joint. This demonstrates an unobstructed projection of the intercondylar fossa and the medial and lateral intercondylar tubercles of the intercondylar eminence. So next we have the AP axial projection Beckler method. So the IR used for this projection is 8 by 10 inches crosswise. So place the patient in supine position and adjust the body so that it is not rotated. Flex the affected knee enough to place the long axis of the femur at an angle of 60 degrees to the long axis of the tibia. So, the central rays adjusted the leg so that the femoral condyles are equidistant from the IR. Immobilize the foot with sandbags. So, the central ray for this projection is perpendicular to the long axis of the tibia, entering the knee joint 1/2 inch below the patellar apex. So, this shows the intercondylar fossa, intercondylar eminence, and knee joint. So next, we have the tangential projection merchant method. So the IR used for this projection is 24 by 30 centimeter crosswise. So place the patient in supine position with both knees at the end of the radiographic table. Adjust the angle of the knee flexion to a 40 degrees. Place the IR perpendicular to the central ray and resting on the patient's shins approximately distal to the patella. So, the central ray for this projection is perpendicular with the IR 40 degrees knee flexion. So, this shows a bilateral tangential image demonstrates an axial projection of the patella and patellofemoral joint because of the right angle alignment of the IR and central ray. The patella are seen as non-distorted, albeit slightly magnified image. Let's proceed to the tangential projection Senegas method. So, the IR used for this projection is 8 by 10 inches. So place the patient in prone position. So flex the patient knee slowly as much as possible or until the patella is perpendicular to the IR if the patient condition permits. So place the IR transversely under the knee and center it to the joint space between the patella and the femoral condyles. So the central ray for this projection is perpendicular to the joint space between the patella and the femoral condyles when the joint is perpendicular. So this shows vertical fractures of bone and the articulating surface of must be 18 by 43 centimeters. So place the patient in supine position. So check the pelvis to ensure it is not rotated. Center the IR, the affected side tie to the midline of the IR. When the patient is too tall to include the entire femur, include the joint closest to the area of interest on the one image with the knee. So place the bottom of the IR 2 inches below the knee joint. The central ray for this projection is perpendicular to the mid-femur and the center of the IR. So this shows an AP projection of the femur, including the knee joint or the hip. So last, we have the lateral projection, medial-lateral. So the IR used for this projection must be 18 by 43 centimeter lengthwise. So let the patient in supinate position and ask the patient to turn into the affected. So adjust the body position and center the affected thigh to midline of the grip. With the knee included, flex the affected knee about 45 degrees, place a sandbag under the ankle, and adjust the body rotation to place the epicondyles perpendicular to the tabletop.